Well, we are on the home stretch. This is your final formal class lecture. Next week I will also post a video lecture, and what it will consist of is review items from weeks 1 through 14. And so you will not have a formal set of notes with that lecture. Rather, it will be just some case studies that I put together that kind of apply all the previous information. So as you can imagine, the quiz, your final quiz, it will just be Blackboard based. It will be just exactly like you've been used to, except it will count as a few more points, and you will have 2 attempts just like you've typically had. And so if you've been wondering about how will the final work in this class, you will have a week to take it just like you've had all the other weeks. And so you really won't notice much difference. I'll post a lecture. The big difference would be you won't have any lecture notes because you've already got those from the subsequent weeks. All right, so today we're going to talk about a section I call tests on body fluids and miscellaneous tests, some tests that didn't fit in when we talked about other systems like neurology or the respiratory system or the abdominal system. We will also next week do that review of course material. So I'll bet if you've watched any of those CSI shows, you've noticed that they seem to collect a lot of blood and body fluids. And so in the hospital we do the same sort of thing, but for a little, usually different reasons. Excuse me. Some of those fluids that we might collect to test would be things like cerebral spinal fluid. If we thought you had meningitis, we might do a spinal tap and collect cerebral spinal fluid. If you have blood, so you know that if you've had any contact with healthcare, it usually involves some sort of blood acquisition, and they test that. In this case, we're talking about how we might test blood for things like bacteria or viruses or fungal infections. We collect sputum to do similar tests. There are samples that could be collected of sputum that help screen for cancer. We collect vaginal and penile fluids, as you can imagine, to screen for things like rape, but also to look for disease. Anything you can think of that's kind of a liquid, we can culture it. So wound drainage, if it looked like it was infected, we might collect a sample of it to see if there really are organisms there. We collect urine, and in fact, if I had to say the most commonly tested body fluids in a hospital, it would definitely be urine and blood. We collect fluid from centesis procedures, so thoracentesis, where we put a needle into the thorax, paracentesis, where we put it into the abdomen. You've probably heard the term amniocentesis, where someone had a sample of amniotic fluid be obtained via a needle. And the most common fluids tested, as I mentioned, were blood and urine on this list. And I would say overall those are the most common fluids tested in any healthcare setting. What kind of tests could we do? Well, if we're screening for bacteria, we might start with a test called gram stain. And if you took high school biology, you might have even done gram staining as part of that. If you took a microbiology class on campus or at another location, you might have done gram staining. Gram staining is going to tell us what shape the bacteria are and whether they're present. So if I was screening for a virus, I don't want to do a gram stain. If I'm doing a gram stain, it's to check for whether there are bacteria present and to look at their shape, because sometimes their shape tells me which antibiotics might be effective, or it might even kind of give me clues as to what organism might be present. The fluid could be urine that we check for with a gram stain. We could check sputum and do a gram stain. When someone's ordering a gram stain, they want fast results, so we can get those results in as little as 15 minutes. But the information is limited, It won't tell us the specific type of bacteria that's present. It will tell us if bacteria is there, and it will tell us the shape of it. So it might be helpful if we were screening for something like meningitis. Meningitis can have a bacterial and viral form. So if we do your cerebral spinal fluid and we check it with a gram stain and it says there's nothing there, we might say then, okay, we've determined that if you have meningitis, it must be viral because we didn't have any bacterial agents present. A gram stain is fast, but it doesn't tell us the specific bacteria type. It does tell us the shape. So some of you have been exposed to this information previously. We had rod shapes that we called certain terms. we have terms that apply to. So coccus is the circles. We have some spiral type of bacteria that are formed, and so we give things names that go with those shapes. So these ones are called Streptococcus if it's the circles of bacteria that occur in a line. I'm not going to necessarily test you for recognizing specific bacterial shapes other than a Streptococcus that's in stripes or strips, a Diplococcus or Staphylococcus, they're in a cluster like a grape. And so that might be the extent of that. We do look at things that stain gram-negative or gram-positive. And so when we do a gram staining test, we put some dyes on that bacteria or on the sample that you collect, and it can tell us if we're trying to kill a gram-positive organism or a gram-negative organism. And the way that this fluid is colored can give us helpful information on that. Alrighty, let's go to a gram stain here. So gram stain, when we look at these, and I have people who say, okay, how can I remember if it's positive or negative if it stains purple? The other color that it might stain is red or pink. So they stain purple or blue, and you can see this one stained a purple or blue color. The other color that you can have is pink or red. They look kind of the same under the microscope. And so when we have a purple, if you think of the word purple, it has two P's in it, and that's going to help you remember that a plus sign has two lines to make a plus sign. So I'm hoping all this makes sense. So if I see organisms that have been stained using gram staining, and they are purple or blue, that means they are gram-positive organisms. And so those are usually things that we would want antibiotics that will kill gram-positive organisms, like maybe a penicillin type thing. If we have organisms that are pink or red, since pink only has one P in it, I use that to remember that a negative sign only has one line. So purple has two P's, and I use it to remember there are two lines that make up a plus symbol. So gram-positive organisms, something that's positive has a plus charge. So gram-positive stain purple or blue, and gram-negative stain pink or red. So if there was a quiz question and it said, are these gram-negative or gram-positive? Hopefully you could answer that correctly now. And just a little humor, my weak attempt at humor for you. Next we're going to talk about bacterial cultures. So if a gram stain would tell me if bacteria are present, why do I need to do a culture? And why do they a lot of times combine a culture test with a sensitivity test? So the advantage of a culture is it's going to tell us the specific bacteria that are present. It's not just going to tell you the shape. It's actually going to tell you this is Staphylococcus aureus. This is Streptococcus pneumoniae, which causes pneumonia, as you can imagine. It's meningitis, or excuse me, Neisseria meningitidis. It tells us the exact organism that's present. And so why do we bother with a gram stain if a culture tells us if bacteria are present and specifically what type they are? Well, look at this. The reports we get back from a culture usually take a minimum of 24 hours, and then because some bacteria can be slow growing, they're going to keep that in that special temperature chamber, and they're going to grow those bacteria for up to 72 hours. Sometimes they'll even go a little bit longer, maybe as long as 5 days. And so if someone was admitted to my clinical facility yesterday and I knew that we obtained blood cultures at that time, I would know that immediately if we got back results, it was probably the results of the gram stain. And that would be helpful because it would tell us the bacteria has bacteria or it doesn't. It's not the bacteria has bacteria or not. The blood has bacteria or not. And blood should normally be sterile. And so if we have bacteria present, we know that we have a condition called sepsis, which is infection in the bloodstream. If we then look for the culture to come back, I know the soonest that's going to come back is in 24 hours. And the advantage of that culture is it's going to tell me the specific organism that is present, and so I can fine-tune my antibiotic selection. Several times they combine the test culture with a sensitivity, and if the sensitivity is done, that's a piece to determine which antibiotic will work. So here's what a culture might look like. We've collected maybe a swab from inside someone's mouth, or we collected wound drainage, and we spread it across this petri dish, and we grew it out. And you can tell there are some different types of organisms growing here, and I bet you can see that based on the way those organisms look. There are probably 5 or 6 different types of organisms growing here. With a sensitivity test, we grow out those organisms, so you can see where they've drug their wand across and grown out a specific organism. And then they dropped onto that petri dish, that collection dish, little antibiotic-soaked papers. And these little antibiotic-soaked papers then would be labeled so that you could see which antibiotic was this one. And I'll bet you can see this antibiotic killed the bacteria around it. So we know that whatever organism the patient has, it is effectively killed by this antibiotic, and we could see which antibiotic that is by reading the little paper. So there's little kind of machine that would drop these medication-soaked pads onto this little petri dish. Tell me about this one then. So is this the antibiotic you would want to be put on if you have this organism that spread on the petri dish? No, because it was resistant, and that's what the sensitivity would report. Is it would tell you beside each antibiotic if the organism was very sensitive to it, or somewhat sensitive to it, or moderately sensitive, or resistant. And so the way that you can be a helpful clinician is if you've had a patient who's had cultures done, then you know to look for those results in 24 hours. And if they had a sensitivity, you're going to look and see they've probably been put on antibiotics if they had bacteria present. You're going to see, are they on the correct antibiotic? And you'll know that because you'll look at your sensitivity list, find the medication they're receiving, and what if you notice that the antibiotic they have says R next to it? Well, then we need to be making a call and getting their antibiotic changed because they have an organism that's resistant to that. And I'll bet most of you have heard of MRSA or MARSA. We have methicillin-resistant Staphylococcus aureus. That's MRSA. And MRSA is resistant to most antibiotics that would normally kill Staphylococcus aureus, one of which is methicillin. So it would, if we said, okay, let's pretend this is Staph aureus, this might be methicillin, an antibiotic, and it would show us the person has MRSA because it was resistant to the methicillin. Okay, ELISA. We have lots of things that cause diseases that are not bacteria. So a really quick review then, if you suspect you have a patient who has a bacterial infection, gram staining might be helpful. If a physician orders gram staining, you would probably say, do you also want cultures? If they order cultures, you might say, do you also want a gram stain? If they order cultures, you might say, do you want a sensitivity done as well? And typically those two would go together, a culture and sensitivity. There are times very commonly where we order cultures and sensitivities and not gram stain, but we probably should never order a gram stain without ordering a culture. I think you understand that issue now. But those things would be effective in identifying if a patient had a bacterial infection. And if you have a bacterial infection, we give you an antibiotic. Antibiotics are effective against bacterial infections, but there are organisms such as rickettsia or viral infections or fungal infections that cause disease as well, and we need to screen for some of those. So chickenpox is one of those, and some of you, if you're going into the healthcare field, you've been tested to see if you have antibodies for chickenpox, and a test that they likely might have done is called the ELISA. In your notes you can see what this stands for, and this is a piece under viral cultures. It says ELISA stands for Enzyme-Linked Immunosorbent Assay. So do you see why we like to shorten things in medicine rather than say that mouthful of words? With this test, what they're going to do is look for an antigen-antibody reaction, and they usually have some sort of color change that will occur to let you know that The patient has that organism, whatever you're testing for. And so in this case with the ELISA, it is a test that is used to look for viral infections. It's also used to detect things like hepatitis, to look for the HIV virus. It's used to look for rubella, and other types of things that your body would develop antibodies for. It will usually have a way to show you that you did the test correctly, and it will have some sort of standard to show you what a negative and a positive will look like. So I bet if you look at this slide, you can see a negative will be this color green, a positive will be this color green, and the assay control means how do I know I did the test correctly? And this should sound a little bit like a home pregnancy test. If you've watched commercials or maybe you've had up close and personal experience with a home pregnancy test, there's a way for you to know, did I do the test correctly, and then am I positive or negative? So let's look at this test, and I'll bet fairly easily you can see what is the issue with patient A, patient B, and patient C. So how would you diagnose patient A using this information right here? How would you diagnose patient B based on this information? And how would you diagnose patient C based on this as being positive and this as being negative? So I'll bet you answered patient A is negative. Patient B, let's come back to them. Patient C is positive. So if this was the HIV test, we're screening for HIV antibodies, then we have a patient who tested positive and a patient who had tested negative, and this patient B who gives us kind of a dilemma. They're not clearly positive because it's not that dark green, but they're also not negative. So we call this an equivocal test. And with an equivocal test, or an indeterminate test, it means the best thing to do would be to repeat the test, and ideally we would use a different method, one that looks for antigen antibodies, but it would use a different process. So we could see if it was just the problem with the test itself. We know we did the test correctly because the assay control was correctly indicated, but is it just that this patient's blood on that day didn't have enough of the antibodies present? If you think of you, if I had come in contact with someone who has, let's say, mumps, it would take me a few days to develop the mumps myself. And during those few days, my body is developing antibodies against an antigen. And so if I had unprotected sex and I went to be tested for HIV the next day, that result, if that's been my only case of unprotected sex, it's going to be negative. It's going to say I'm fine. Well, I really may not be fine. I just haven't waited enough days for the antibodies to build up to a level sufficient to be tested. Western blot is another way to screen for those same sorts of things that ELISA could test for. Western blot is also an antigen antibody test. So when I go to donate blood, they take some of my blood and they do testing for things like HIV. They test for common viral organisms. They want to try and make sure that my blood is safe. They're going to test that using ELISA, and if anything shows up as a positive or an equivocal or indeterminate, they're going to repeat that using Western blot. So I bet you can expect that if someone tested positive in an HIV test using Western blot, they would repeat that test using maybe ELISA. Okay, let's look at this one. We have that same sort of thing that's common to these types of antigen antibody tests. They're going to have, here's what a negative will look like, here's what a positive will look like, and there's usually another one that will tell you if you did the test correctly. This one doesn't have that one exactly. Then we have patient numbers over here. So how would you, can you find the positive patient? So that one stands out pretty easy. Can you find some patients who are negative? Well, we would probably say this one was negative. But what do we say about these patients who have clearly more lines, many more lines than just nothing? So we would say these are equivocal or indeterminate. What does that mean? Repeat it using a different method of testing, and or have the patient wait a little bit longer. It may be that they have not developed sufficient antibodies yet. and then repeat the results. Another way that I would apply this is many of us when we're in healthcare, we're given the option of being vaccinated for hepatitis. And if I were vaccinated with the hepatitis vaccine, they have me wait 30 days and then come back and have my blood tested to see if I've developed antibodies. And in fact, they give me 2 vaccinations about 3 months apart, and then they have me come back so my body will have had sufficient time to build up antibodies. For flu season, we get a vaccination, and when we're given that amount of vaccine, it causes our bodies to produce antibodies against what they think will be the flu strains. But if I were tested, I wouldn't show positive for the flu test if I just got the shot yesterday. It would take a few days for my body to build up those antibodies. So similarly, if someone's exposed to HIV or Rocky Mountain spotted fever, some of those stranger viruses that we hear about, it's not going to do any good to do gram stain or bacterial cultures because those are a different class of organism. Okay, before we go on from page 1 in your notes, there was a little blurb on viral cultures, and it just mentions that viruses are difficult to culture because we have to grow those in living tissue. And so that kind of explains then why we go into tests like the ELISA or the HIV testing. We can do viral cultures. They have to be written specifically as a viral culture so the person who collects those specimens knows to put them on the agar that has the living tissue or to put them in a vial that has living tissue like a blood in it. And then those may take much longer to get the results back from. So we usually want fast results. Can you imagine what if you're running a screening for hepatitis patients or for HIV patients, and you know that they're not going to come back or call back in 3 weeks and find out what their results are, or 2 weeks and find out what their results are. So you'd like to be able to get them really quick testing. Nucleic acid testing is a new type of technology that our blood donation system is using to screen blood now. They're using Western Blot or the ELISA, and they are also using nucleic acid testing. The advantage of this is when I talked about Western Blot or ELISA, I said it takes a while for your antibodies to develop. Well, when they do nucleic acid testing, they're still looking for evidence that you have been in contact with a virus or something that would cause you to become ill. And they are looking for pieces of the RNA or DNA of that virus. So they're going to take a sample of blood. They're going to look for evidence that you have that virus, but it can diagnose it much sooner than what the ELISA or the Western Blot would have been able to do. So this is the real nutshell of this slide. Nucleic acid testing may improve safety by identifying viruses even before the body begins to produce antibodies. Where ELISA and Western Blot were looking at antibodies, this is looking at the actual RNA or DNA of different types of viruses. Okay, so I hope that kind of helps. It's going to be maybe definitely the more expensive test, but it's one that will get us much more rapid results, and it's looking at a different type of thing rather than the antibodies. It's looking at actual remnants of the bacteria, or excuse me, not the bacteria, the infection. Okay, latex agglutination. Agglutination is clumping. So again, it's an antibody antigen type of test. And you can see some of the fluids that we might do latex agglutination on. The one that I see most commonly tested in the hospital is probably urine. The advantage of latex agglutination is it's kind of like a gram stain, but it's like the gram stain for viruses and things we don't normally screen for. It's infections that are caused by things like viruses. Or maybe we have a common organism that we think causes neonatal sepsis, which would be infection in the bloodstream of a baby. If we know the top 4 things, even if they're bacteria that cause those, we could just say, what if we had a test called the latex agglutination? And an example of a latex agglutination test is blood typing. An example of latex agglutination is a pregnancy test. It's going to do antigen antibody testing. And so you can see, did clumping occur or not? And that would give us an answer as to whether you do have that antibody for a specific antigen. Strep stat. This is another example of how we're trying to get more rapid results, information to patients. If I went to my physician 10 years ago and I thought I had strep throat, they would take a swab from the back of my throat. They would grow the culture in a dish because strep throat is caused by a bacteria. They would then say, we're going to grow that culture. Do you remember what the minimum time is we're going to grow the culture? They would say, wait 24 hours. Call us back at our office in 24 hours. We'll tell you if you have strep throat, and then you can come in and get your prescription for your antibiotic. Well, now what happens is, if I think I have strep throat, I go to my physician. They do a culture in their office. They take that swab and they go back to a device that looks like this. Looks like a lot like a home pregnancy test, doesn't it? But this one is screening for strep antibodies. They kind of take your swab and rinse it with sterile saline to make it coat this dish. That sounds a lot like a pregnancy test. And then you have a control and a test. You see this one's been done. It shows that the person has strep and that the test was done correctly. This one shows the test was done correctly. Wait a minute. Oh, control. Control. The test was done correctly. The patient doesn't have strep. This is the test thing. This person, it hasn't been used. This person, they did the control and the person has strep because it shows the line under the test. So control, did I do the test correctly? Test results are under the T for this one. I'm sorry. Okay, for a monospot, what do you think they're screening for? If a strep stat was for strep throat, what do you think monospot is for? We get quick results for mononucleosis. So we're going to take a blood sample and we're going to screen rapidly to see if you have antibodies against the organism that causes mono, which is a virus, Epstein-Barr virus. A lot of these rapid home tests are nothing more than antigen antibody tests for specific organisms or viruses. So hepatitis C check, I can do that in my home. I can do a HIV test in my home. Can you kind of think of why they might have people do these in their homes? And while that's a nice feature that I don't have anybody knowing my results but me, it could be dangerous too. If people, how often do you think people read the instructions? How many of you would be guilty of doing the test results and really not knowing what they might mean? Or how many people go out and have unprotected sex, buy their HIV kit at the store the next day, they test themselves and it says they're negative, so they think they're okay, when really they don't understand these things rely on antibodies. And if I've just been exposed, my body would not have enough antibodies to show that I have tested positive, even though I might. You can do drug screening at home too. So if you have an unruly kid, or just think of how bad this could have been for you if your parents did their own drug testing at home and checked you. So some other pieces that didn't really fit anywhere else. Now we are to the bottom of page 2. And I just have some listed in your notes and some listed on these slides. In your notes I have one about the H. pylori test. We've identified that Helicobacter pylori causes some cases of reflux and some cases of stomach ulcers. And so in a person who has reflux or stomach ulcers, we might actually do an H. pylori culture to see if they have that organism that seems to put patients more at risk for things like stomach ulcers. There's the Anna-Sal HIV test. You take a saliva sample and you can test to see if you have HIV antibodies in your saliva rather than get blood. Because as you can imagine, in these kits, they're not having you draw your own blood at home. They're having you use other body fluids like urine or saliva. Now we go to those miscellaneous tests. And on page 3, I do have a little piece there that finishes up the ELISA and Western blot where we've already talked about. We know that there were positives and negatives, but what if I have neither positive or negative? And so we called it equivocal, or an incomplete, indeterminate test, and it just talks about what they might do with those. Okay, now let's move on. I'm at the bottom of page 3 if you're following along in your notes, and I've got just a few more tests that I'm going to review with you. One of these is intradermal skin testing. And if you have allergies, if you enter healthcare and you think you might have a latex allergy, you're counseled to go to a dermatologist or to an allergy test person, an allergist, there we go, and be tested to see if you truly do have a latex allergy, because that can be something that worsens the more you're exposed to it. We have people with asthma that can be allergic in nature, and so we might have them get some testing to see if there are things that can minimize their asthma-like symptoms. If we can control the allergens, can we control their asthma? So this person has gone to their allergist, and they have had injected under their skin some little amounts of antigen. And this is another antigen antibody test. This one is actually letting the skin do the determination for us. These are numbered because there would be a record kept of what these are for. So think of things that you know people are allergic to. I bet you could rattle off a few. We know peanuts. I bet you thought of that one. There are people allergic to dust mites, or pet dander, or milk, or wheat, or different things like around the Boise area we have pollens mainly from the sagebrush or the cottonwoods. So if we say to someone, I have really bad asthma that acts up especially in June, the dermatologist or the allergist might say, well, let's test you for sagebrush, or let's test you for cottonwood. And so they would inject a small amount of that antigen under your skin, and they're looking for a thing called a wheal, which would be a red raised area. So isn't it amazing what people put on the internet? So here's this young man who had his allergist inject him with those little amounts. I'm sure the numbers have been washed off now, or the little tabs that were placed beside them that told him the specific ones. And so he took this nice picture after getting home from his allergist appointment. Each one of these is called a wheal. So they injected the medication. You wouldn't see it turn red just based on that. The redness is caused by the skin recognizing, or the body recognizing, that that is something you are allergic to. So a red raised area is a wheal, W-H-E-A-L, and it would tell the dermatologist or the allergist that's what you're allergic to. And the purpose of doing allergy testing is then they could develop a vaccine for you, or an injection that would make you less sensitive to those things that you're allergic to. Okay, TB skin testing. They're going to inject a small amount of antigen to see if you've been exposed to tuberculosis. And hopefully you don't develop a wheal, because then that would mean you don't have antibodies against tuberculosis. And this is something healthcare providers are tested every year to see if they have antibodies against tuberculosis. So how do we determine a positive and a negative? In the case of tuberculin, it has to be more than 10 millimeters. And so do you see that this person definitely had more than 1 centimeter of raised red area? And so they should have measured from here to here, the red raised area. This person has a positive TB test, which is not a good thing. Okay, cytogenetics, a piece that didn't fit anywhere. With cytogenetics, this is the area of medicine where we connect or collect your chromosomes, and it's kind of interesting how far we progress in medicine. I do clinical in the newborn intensive care unit, and when we needed to collect chromosomes on a baby to determine if they have a genetic defect or a birth defect, and the difference is one is due to chromosomes. If they're trying to determine if they have a genetic defect, they collect chromosomes. So they would have someone kind of stabilize and hold the infant while their skin was kind of numbed, and then they would pass a needle into the bone marrow of the pelvis. And as you can imagine, as that needle crunched through that bone, that was not very comfortable, even if we tried to make the infant comfortable by giving some agents to kind of numb that area. It's still a very painful test. Well, then think about how they collect chromosome or genetic makeup on the CSI shows now. We do that, and we do it with the ability to take a cheek swab. So some brilliant person finally remembered that class we all had on the chromosomes that are in one cell are the same ones that are in your whole body. And so why don't we take chromosomes that you get rid of or cells that you get rid of all the time, like inside your cheek? So they take a cheek sample now, and we can look at your chromosome makeup, and you know that pretty much all of us have 20. This person has 22 sets of chromosomes and then a double X, so they would be a female. So we could see what is the makeup of this person's genetics. We know, I bet you've listened to news or reports that tell you if someone has a defect that's caused by their genes, we can identify which gene that might be and try and do some sort of correction. So there's a lot of testing right now and a lot of, I guess, research aimed at if we can identify what's wrong with you, can we figure out a way to fix it. Some of those would be cystic fibrosis is a genetic defect. Down syndrome is a genetic defect. There are some genetic carriers for prostate cancer, for things like hemophilia, for alcoholism, for some types of depression. So the list goes on and on and on. Some people are concerned with what we're going to do with this information. So I know that when I got married, my husband and I had to have a blood test, and that blood test was used to see if we were compatible, if we were going to have children who would have birth defects. And if we had the potential for that, I guess there would be a way that we could meet with a genetic counselor. And they've done away with that now. And I think part of the reason is our nation has decided is our right to tell people whether they have a right to marry or not based on genetics. And what I mean by that is, I bet you remember back to the Hitleristic society where a certain ruler decided, Hitler decided that people should be blonde-haired and blue-eyed and be tall and be athletic. Can you imagine that people might make designer babies with this information? That in some countries, including the United States, people might have an amniocentesis done. They would look at the chromosomes of the baby and say, well, if they're not perfect, we don't want that child, and so I'll have an abortion and then try for another one. And so there are definitely people who are concerned with what are we going to do with the information. We have mapped out every gene in the human body now. That was called the Human Genome Project, and because of that, researchers are much more able to identify what changes occur in genes that put you at risk for certain diseases or cause certain diseases. And so I want you to think, for you, would you want to know, because you could go in right now and have your body mapped. You can know your chromosome makeup, and they will give that to you for about $200 to $400. It's going to tell you every disease that you have the potential to get, or the chromosomes that put you at risk for a disease. So some of these you know you're going to have that happen. Would you want to know that you're going to have Alzheimer's as you get older? Would you want to know if your baby has a risk for cystic fibrosis? Do you want to know if you're a cystic fibrosis carrier? So there are in some ways that information could be helpful, but what if I have the chromosomes tested for my child, and from the time they were a few months old, I knew that they were at risk for some disease? Is there a potential that I might treat them differently? That I might say, well, I don't want you to go out and play that sport because it's dangerous and you're already at risk for this. And at what point do I tell that child? Similar to, how do I tell a child they're adopted? When do we have that conversation? When do I have the conversation with my child that I know they have a higher than normal risk of developing Parkinson's disease or some other condition? So I think you can see this opens up a whole range of possibilities, both with positives and negatives. Because it's out there, it's something that's having to be dealt with now. And like I'm telling you, you could go to a physician now and say, I'd like to know my genetic makeup. They would charge you some money, give you the results, and then what do we do with that information? So in some cases it can be very helpful. I might like to know if I'm a carrier of cystic fibrosis and if my husband's a carrier. That would be more likely to be useful information if I know I have a history of that in my family, and I really do want to know what the odds are of having a child with cystic fibrosis, so that maybe we make determinations about where we live, where they could get good health care, things like that. Okay, other little tests that didn't fit anywhere. The Hcg test is the fancy name for a pregnancy test. And when you do a pregnancy test at home, it is not a fancy test like the Hcg when it looks for antigen-antibody reaction or it looks for the presence of a certain hormone. When you go to the doctor's office, he takes a sample of blood or she takes a sample of blood, and they actually measure the level of human chorionic gonadotropin, which is a hormone that's produced when you are pregnant or when you have certain sex organ tumors. So there's a type of cancer called hydatiform mole, and it is one that simulates a person who's pregnant, and it can happen in males or females. So if you were in the hospital and you see in a patient's chart who's a 50-year-old male that they had a pregnancy test, you might think, oh, I'll bet that's an error, but because you've had this lab values class, you're going to know, I'll bet they were screening for a type of sex organ tumor, a hydatiform mole. If it was a postmenopausal woman, we might screen and do a Hcg test, not because we think they're pregnant, but because we're looking for that type of cancer. So, obviously, if this is called the pregnancy test, one of the more common reasons for doing it is pregnancy. And the advantage of doing this test is because the physician gets a level. There were some studies that showed the higher the level, the more likely you were maybe to be the person who is going to have a miscarriage. So when you go into your doctor and you say, hey, we did 6 home pregnancy tests, they all showed I'm pregnant, I know that I'm pregnant, and the doctor says, well, we're going to run a pregnancy test, do you understand they're doing a different type that actually gets a level of Hcg, not just a positive and negative on a little stick somewhere. What would happen, to go back to some older lab values data that we've talked about, what would happen with your ALP levels if you're pregnant? You remember that this was one we talked about when we did the liver profile tests, and we said that L can help you remember liver, that's not really what it stands for, and P can help you remember placenta. The ALP levels elevate when I have liver damage or when I have a placenta present, or this is the other one that elevated if you had bone cancer. Okay, other tests? There's a whole list of them. Prostate-specific antigen, the Psa test, which is a screening test for prostate cancer in men, has been in the news lately. It's had good press and bad press. At this point, most physicians will still do a baseline screening and kind of watch that number, but they found that it's probably most useful in patients who've had prostate cancer, who then have been treated, to determine if their prostate cancer is staying in remission. So they'll track those levels of men who've had prostate cancer. Cystic fibrosis carrier test. That's just there to remind you that because we've mapped the human genome, and if we can find diseases that are genetically tied, we are probably going to start seeing more and more carrier type tests. So you could maybe have a health fair where instead of getting your blood pressure checked and your spine to see if it's straight, they might be offering carrier testing to see if you carry certain diseases. The rheumatoid factor. We know that patients who have elevated rheumatoid factors are more likely to have rheumatoid arthritis. It's definitely not a cause and effect relationship, because some people have elevated rheumatoid factor and have much milder or no cases of RA, rheumatoid arthritis. Homocysteine. I mentioned this with the cardiac lecture, but homocysteine I think is going to play a little bit more important role, kind of one of those lab values to watch. We know that in people who have elevated homocysteine levels, their risk of cardiac disease and blood vessel disease is increased. And homocysteine levels are easily decreased by taking something called niacin, which is vitamin B6 or 12. And so if I can easily lower it by my diet or by taking a supplement, will that impact whether I have lower risk of heart disease? And this is kind of being studied. They thought they would see significant reductions in risk of heart disease in patients who took niacin. A statin drug kind of does a similar type of thing, but so far they have not seen the response they thought they would with just regulating homocysteine levels. BRCA and BRCA2. These are breast cancer carrier tests. And I'll show you why those are significant in just a minute. And I think you're going to see more of these. Again, these tied to the genetic genome project. So if we find that people who have certain genetic makeup are at higher risk for things like breast cancer or ovarian cancer, would it be helpful to know? So let me show you how this could be very helpful information. I've talked quite a bit about a harmful piece of it, the conversation you might have with your children. How do I tell them that they might be at risk? What I want to know if I'm at risk for certain diseases. Well, here's one why the data might be helpful. If you look at how this chart is oriented, it says the probability of breast or ovarian cancer in women and their age. So with no risk factors, and I don't have the breast cancer mutation, look at my risk. It's fairly low that I'll develop breast cancer even though I become older. If I have a family history of breast cancer, my chances increase about 40%, the probability of having breast cancer. But if I am 30 or 50 years old and I know that I have that breast cancer mutation, do you see how astronomically my chances of developing breast cancer, especially later in life, increase? And so if I knew this information, would I be the kind of patient who would say, I'd like to have a mastectomy even though I don't have cancer yet to avoid getting it? Am I the person who says, I'm done having children, I'd like to have my uterus removed so that I don't, and my ovaries removed so that I don't develop ovarian cancer because I know I have a BRCA mutation? Again, they use this information and watch these numbers. You hear people call BRCA. And do you see how that kind of would be pronounced BRCA? So BRCA1 and BRCA2. I could look at my risk of developing breast cancer based on genetic mutations. Do I have those? They try and make these things user-friendly so that some of them could be done at home. Here's a Psa test that you do at home, very similar to how you do a pregnancy test. So a control, a result, and then I think this was like the test, another backup for the test. So I don't know the specific instructions for this one, but there'd usually be a way for you to know, did I do the test correctly? So a little introduction to antigen, antibody, blood and body fluid testing, and then kind of some miscellaneous tests. Your quiz will be up, and if you have any questions, you're always welcome to ask. You can email me or call me or post a question on the Blackboard. So thank you very much. Now I just have to find where I stop this.